Hello guys, my name is Ashley Seymour and today I'm going to be telling you about factitious disorder. So let's look at the core characteristics of factitious disorder. Factitious disorder is characterized by the deliberate falsification of illness or injury in order to achieve a desired and unconscious outcome. The individual is aware that they are falsifying an illness and that they are making it look as if they have this illness to medical practitioners. There are two subtypes of factitious disorder. There is factitious disorder imposed in the self, which is when one falsifies an illness in themselves. And then there is factitious disorder imposed on another, which is when an individual falsifies an illness in another person. And this tends to be a parent, specifically the mother, falsifying an illness in their child. This pattern of abuse is known as Munchausen syndrome by proxy. So the condition in the individual falsifying is FDIA, and the pattern of abuse is Munchausen syndrome by proxy. These conditions are incredibly difficult to diagnose and they present with long-term medical risks. So the main feature of factitious disorder is the fact that illnesses are fabricated. Illnesses are fabricated through multiple methods. One of these can be just lying about the symptoms experienced by the person who has factitious disorder, either about themselves or about the person that they are trying to present as ill. The individual can also exaggerate symptoms or make symptoms worse. They can even induce symptoms by making themselves or another person sick. A lot of the time when we look at cases of factitious disorder imposed in another, that person will force the other person to ingest poison in order to present with some kind of illness. In addition to this, people with factitious disorder imposed in another may withhold treatments for their child so that that child becomes more sick, or they may even encourage their child to lie as well and lie about symptoms that they may have in order to receive specific treatments or medical care. There are some features that clinicians need to look out for when considering a case of factitious disorder. Firstly, an atypical disease presentation where the disease claimed by the person with factitious disorder does not meet the symptom profile of the disease itself. Also, factitious disorder typically presents in clinical settings such as hospitals and doctors' offices. The person presenting with factitious disorder is usually an expert in medical terminology and can use this terminology to persuade medical professionals to perform specific procedures or tests. And finally, when clinicians test the sick presenting individual, they typically find that the results of these tests are inconsistent with what the factitious disordered person claims. This condition is often referred to as hospital hopper, as the person who is presenting with factitious disorder will often move from place to place or hospital to hospital when the clinician becomes suspicious that they may have the condition. So, how do we make a differential diagnosis of FDIS? There are 4 criteria that the DSM specifies need to be met in order for a diagnosis to occur or be possible. The first of which is that falsification needs to be confirmed. There needs to be some kind of objective verification that the person is falsifying their condition. The next is that the individual has to present themselves as ill, injured, or impaired. The deceptive behavior needs to be evident without external rewards, and I'll talk about that with malingering. And finally, the behavior cannot better be explained by another disorder such as delusional disorder or psychotic disorders, where there is some kind of belief that the individual is sick despite no evidence to suggest that. In the case of FDIS, there is a lot more work into falsifying and presenting false symptoms. Psychotic disorders are a lot more focused on the belief of disorder. And in FDIA, the conditions are very similar. However, the core difference, of course, is that the individual with FDIA falsifies an illness in another person, not themselves. So, the one consideration that we need to make when conducting a differential diagnosis is the concept of malingering. In malingering, we have an individual who also falsifies an illness. However, they don't do it for an internal motivation. They do it for a very obvious external motivation. They are either doing it for some kind of financial gain or to avoid some legal process. And this condition usually goes away once that goal has been realized. Whereas with factitious disorder, it's a continuous condition where the individual continuously fabricates illness to achieve the sick role. They get to be a caregiver or they get to be sick themselves, and both of which is beneficial to that person. Some things to consider as well when making a differential diagnosis is that you have to be able to objectively confirm the diagnosis through testing, confirm that these discrepancies have been present with other healthcare practitioners, and in some cases conduct surveillance on the person suspected to have a factitious disorder to confirm that they are in fact fabricating their symptoms. Etiology in people with factitious disorder is complex and cannot be pinned down to specific influences. However, there are features that are consistent throughout the progression of factitious disorders. Firstly, factitious disorders are recurrent and they often present throughout the lifespan. Secondly, factitious disorders often have or present with other comorbidities, mainly depression, but there are others. There's also a history of illness or trauma in the individual who presents with factitious disorder. Usually they themselves experienced illness at an early age, or they experienced family trauma or family illness. And finally, most people with factitious disorder decide to impose or induce an illness onto themselves or another. What that means is that they create the illness in themselves or the other person. They don't fake it. They actually do something to create symptoms in themselves or another person. So the main kind of approach to understanding how factitious disorder presents is by looking at development, and many people believe that factitious disorder is actually a developmental disorder due to the fact that factitious disorder can be seen in adolescents and young children and progresses from there. However, the way in which this is kind of developed is not so clear. There are three main theories for how factitious disorder could technically be encouraged. The first of which is an intrinsic pathology in which occupying a sick role is attractive to the individual because they struggle to cope with life's demands, and so occupying that role is beneficial for them. The other is that the individual learns that occupying a sick role is successful. Either they've observed it from other people, so someone in the family when they were younger was successfully cared for and that seemed beneficial to the child, or they were sick and received the care that they didn't receive without being sick. And so they learned that sickness was a good way to receive attention and the care they needed. Or finally, there was some deficit in attachment, and this resulted in the individual not being able to securely attach to their caregiver, and subsequently decided that occupying a sick role or inducing a sickness in someone else would allow them to occupy a secure attachment through being a caregiver or needing to receive care in a family context. So these three different developmental pathways encourage certain speculation around how this condition could develop. So gender plays a very important role in the presentation of factitious disorder. Most of the people who present with factitious disorder typically are women. However, in FDIS, there are men who also present with this condition. However, in the case of men, they will present with a slightly different set of suspected conditions or presentations. They will claim that they more likely have something like a cardiac problem, whereas women are more likely to claim problems that are psychiatric or oncological. There are a few that women are more likely to claim and men are more likely to claim. However, in FDIA, 95% of the people with FDIA are the mothers of the victims, typically women. However, it can very seldomly be men and other caregivers as well. So in the South African context, there is a deficit of research on the presentation of factitious disorders. And given the fact that there is limited access to healthcare resources, specifically in poorer and more rural regions of the country, it is much harder to identify the prevalence of this condition amongst people in these regions. People may also be discouraged to attempt to falsify an illness in these contexts, as it is so difficult to gain access to these places. And potentially, one may want to consider less conventional settings for the presentation of factitious disorder in this country. It's also worth noting that there is difficulty in identifying the prevalence of factitious disorders due to deficits in healthcare practitioners' knowledge of these conditions. It was identified that social workers in South Africa did not have the full understanding of factitious disorder required to make a diagnosis. So, as previously discussed, the impact on families and loved ones is significant in factitious disorder. In the case of factitious disorder imposed on self, those who have this condition will often sacrifice their time with loved ones to access healthcare and access support as a sick person. And so they may jump from healthcare facility to healthcare facility in order to continue to receive care when a previous facility neglects them. And as such, this may also have economic and emotional implications. In the case of factitious disorder imposed in another, the consequences are much more obvious, in that the person in who the illness is being falsified is often at the end of extreme medical practices that threaten their medical well-being. And there is a prevalence of mortality in children who have been exposed to factitious disorder. In addition, children who are exposed to FDIA are actually likely to continue that practice on themselves and report false symptoms or falsify illness later in life. So how do we prevent factitious disorder? Very, very difficult, given the fact that its etiology is quite varied and unspecific. However, medical practitioners are responsible for being very conservative with how they approach those with atypical symptom presentations or atypical disease profiles, as well as how they approach the treatment of apparently sick individuals. It's important to corroborate reports. It's important to follow up on additional information about patients, and it is also important to be very wary of those who recommend very invasive procedures for their children. Thank you very much for listening to this presentation. Here are some references for you to consider, and I hope that this was informative for you. Thank you very much.